Good morning, everyone. It's 8:05. Welcome to the academic meeting this Friday. This week is presented by the Department of Neurology, and I'm going to hand over to Prof. Mochan now to host the meeting.
Thank you, Jared. Good morning and welcome to the meeting, everyone. Colleagues, nice to have you around. I just saw that nice note from colleagues in Carlton. Well, wonderful to have you on board and participating. I think it's a great forum, and thanks to the Department of Medicine for hosting or having us today. And we have Dr. Jerry George, one of our registrars, presenting on a topic which is kind of a quite common complaint in general practice and spans a wide range, array of underlying issues, many harmless and some perhaps more sinister. And he will take us through that, and I hope it will be an enlightening and informative talk. Thanks for doing it, Dr. George. Please, the floor is yours.
Thank you, Prof. Good morning, everyone. My name is Jerry George. So today I'll be talking about an approach to lower back pain. So this is the outline of my talk. I'll be going through the definition, the epidemiology, followed by the anatomy of the back. Then I'll go through some causes of back pain, treatment, and then the references. So the definition of lower back pain. This is pain that is located below the costal margin, but above the superior gluteal fold, which may or may not be associated with lower limb weakness. So with regards to the epidemiology of back pain, it's got a lifetime prevalence of 85%. The most affected age groups are between the ages of 45 to 64 years of age. Women are more affected than men, and they also have a higher recurrence rate. And the risk factors that are found are markedly obesity, increasing age, manual labor, smoking. Psychosocial factors is also a very big risk factor. Then back pain has got a massive socioeconomic impact. It's actually the most common cause of absenteeism from the workplace. It's one of the top 10 causes of disability adjusted life years. So this is a very important topic. So with regards to the anatomy, I'll go through basically the anatomy of the back from inside outside. So we'll start with the spinal cord. We know the spinal cord is roughly cylindrical in shape. It starts from the foramen magnum to the lower border of L1. The spinal cord itself doesn't have any nociceptors. But if the tracts are irritated, it can have tract pain. And know that it's surrounded by 3 meninges, the pia, arachnoid, and dura. Then we know that the spinal vertebral column has got 33 vertebrae. So here's basically a diagram. You can see the cervical 7, thoracic 12, lumbar, sacrum, and coccygeal 5, 5, 4. And so this diagram is basically just telling us about the typical vertebra. So we can divide it into anterior and posterior elements. The anterior elements basically is the vertebral body and the disc above it. The posterior elements is everything in blue here. We can see the pedicles, the lamina, the transverse process, spinous process, and the green is the superior articular process, and you've also got inferior articular processes at the bottom. Then the joints between the vertebra, the important one, the joints include the intervertebral disc, and they've got 4 articular processes. So here we can see the intervertebral disc in blue between the vertebra. Then we've got 4 articular processes, the facet joints. Basically, it's the articulation between the 2 superior articular processes of the vertebra with the inferior articular process of the vertebra above it. And this is actually a very important cause of joint pain or back pain as well. Then this is the sacroiliac joint. This is basically a joint between the sacrum and the ilium of the pelvis. It's held in place by 3 ligaments, 2 anterior and posterior sacroiliac ligament and a sacrotuberous ligament as well. Then another important joint is the pars interarticularis. Basically, this is a point of the vertebra between the superior and inferior articular processes. It's very important because if this breaks, it can cause significant back pain. Then the ligaments of the vertebra, here we've got the supraspinous ligament. It's basically between the tips of the transverse process. The interspinous ligament, this is between the from the superior border of the spinous process to the inferior border of the next spinous process. We've got the ligamentum flavum, it's basically running between the lamina. Then we've got the posterior longitudinal and anterior longitudinal ligaments. Then with regards to muscles of the back, we can divide them into three groups, basically. Superficial group, which is associated with movements of the shoulder, intermediate group, which is associated with movements of the thoracic cage, and the deep group, which is associated with movements of the vertebral column, also called intrinsic. So these are the superficial group. You can see the trapezius, latissimus dorsi, and the rhomboids and levator scapula. They help with movement of the shoulder. The deep group, intermediate group is actually the serratus. They help with the movement of the thoracic cage. And then the deep muscles of the back, the intrinsic layer, they again further divided into three: superficial, intermediate, and deep. And they help with movement of the vertebral column, like lateral flexion and extension. So here's the three layers: the splenius capitis, splenius cervicis, superficial, the intermediate being the semispinalis and multifidus, the deep being the spinalis, thoracic component, longissimus, and iliocostalis. Then we know that the spinal cord has 31 nerves. Each has a ventral root and a dorsal root, which form together to form a spinal cord. They split into a dorsal ramus, which basically supplies the paraspinal muscles and the dermatomes of that particular level, and a ventral rami, which basically supplies the rest of the sensory motor functions. So this is just a diagram just to show the dorsal and the ventral root as they come together. So when we look at back pain, we have to look at which structures in the back can produce pain or are pain generators. So these include the dura mater, intervertebral disc, the vertebral body or the periosteum of the vertebral body, the ligaments that I mentioned earlier on, the facet joints, muscles, subcutaneous tissue, and the brain. So the psychosocial component is also very important when it comes to back pain. So just to talk about the innervation of the back, so we can divide the innervation to the back into a ventral portion and a dorsal portion. The ventral portion includes the posterior longitudinal ligament and anterior to that. So the posterior longitudinal ligament, the dura mater, the intervertebral disc, and the periosteum of the vertebral body. These are actually supplied by the sinovertebral nerves or the Luschka nerve. It's a recurrent branch of the ventral rami. So this German scientist discovered this. Then the dorsal portion includes basically everything posterior to that. So these include the facet joints, the remainder of the ligaments, spinal muscles, and these are innervated by branches of the dorsal rami. So this diagram is basically just showing this recurrent meningeal nerve there, and dorsal portion will be supplied by branches of the dorsal nerve. So this is just a diagram showing the different dermatomes. It's important for us to know this because it can help with localization. So we need to know which area of the skin is applied by which particular dermatome. Then this is basically a table showing nerve root level and movement involved. So if we can try always remember which root level is associated with which movement, we can work backwards if there is a radicular type pain or radicular or like a myotome that's affected. So like, for example, L2 we know causes hip flexion and hip adduction. L3 causes knee extension. L4 is ankle dorsiflexion. L5 foot inversion, hip extension, hip abduction. S1 foot eversion. So this is important for us to work our way backwards to try and figure out which nerve is involved, if it is nerve involvement. So when we look at back pain, there's different ways we can look at back pain. We can divide it based on the types. So we can divide it into local, referred, or radicular. We can divide it based on the duration, which is acute, subacute, or we can divide it based on the location and the pain. So this could be like back pain with lower limb pain, back pain without lower limb pain, lower limb pain without back pain. I decided to go with the first type, the local, referred, and radicular type. So local pain, this basically is it's described as a sharp, aching pain felt near the affected part of the spine. So this is basically any process that affects the structures of the back, which have sensory nerve endings, which I mentioned earlier on. But this of importance doesn't involve the nerve roots. So there's no radicular type pain. So we can see there's two MRIs basically here, one showing like signal change basically of the bone and the disc, same here, and it looks like there's no nerve involvement in these cases. So radicular type pain, this is pain that occurs when the nerve isn't affected or involved. So the pain will then course down the distribution of that particular nerve. is due to stretching, irritation, or compression of a root proximal to the intervertebral foramen. So basically, any lesion that now starts to affect or impinge a nerve can cause radicular type pain. And the type of pain will depend on which nerve root or roots are involved. So here we can see basically a diagram. This is the L4, L5 intervertebral disc. You can see this is a disc bulge. And on the right, we can actually see this disc bulge is actually impinging on the nerve. So we're going to expect patients to have pain or even weakness down that nerve distribution. So referred pain, this is basically pain from elsewhere that can be referred to structures in the back. So I'll go through the different, all of these types of pain, different causes of pain in a little bit of detail. Local pain is one of the big ones. It accounts for about 80% of cases of lower back pain. This is basically due to a pathological process that affects structures surrounding the vertebral column. Sometimes we also call this musculoskeletal pain. It's described as a dull, aching, or diffuse pain. Causes include facet arthropathy, spondyloarthropathies, sacroiliitis, discitis, paraspinal muscle strains. So I'll go through a few of these. So facet arthropathy, this is the facet joint that I mentioned earlier on. Most commonly, it's due to OA or even trauma or inflammatory conditions such as rheumatoid arthritis or ankylosing spondylitis. So the progression generally of this is initially there's arthritis of the joint. This is called spondylosis. Then there could be fracture of that pars interarticularis that I mentioned earlier on. That is that area between the superior and inferior articular process. Then there's called spondylolysis. And then they can actually be shifting or displacement of the vertebral column anterior due to that fracture. So this is now called spondylolisthesis. And this can cause significant pain. And it's usually local unless it involves this nerve as it's being displaced. So risk factors of this for facet arthropathy include obesity, manual labor, and the pain generally is non-radicular. It's located lateral to the spine. It's worse in the morning and after periods of inactivity. It's worse on basically movements that involve that particular spine. So examination, there's pain on palpation, pain on axial loading, and positive Kemp's test. Basically, we're trying to mobilize that joint, and of course, if that joint is involved, there will be pain. So Kemp's test is rotation and lateral flexion to the side of that pain. So we're just mobilizing the joint, which will lead to pain. So diagnosing this, it's a bit difficult because there was actually studies done, and between the ages of 60 to 69, one study showed that about 89% of people do have degenerative changes of the facet joints. So this basically means that not all people with degenerative changes will have pain. So it's not necessarily that, so even if we find degenerative changes, we don't know if that is a pain generator in that particular patient. But the gold standard is a medial branch block. You can actually inject a local anesthetic to the joint, and if it gets better, then we've got the diagnosis. The treatment for this is generally conservative. We give analgesia, physical therapy as tolerated, muscle relaxant. So with pain, with back pain, you must exercise as tolerated. It's shown to be much more beneficial, improves outcomes, and fastens the recovery if you can exercise as tolerated. Doesn't overdo it, but as you can. But keep in mind, in this case, yet there's still no nerve involvement. Then in rare cases, we can actually even ask for radiofrequency ablation of that particular joint. Then this is just basically a diagram showing, this is basically fracture of that pars interarticularis. So it's a spondylolysis now. The next one I'm going to talk about is sacroiliitis. Basically, this refers to inflammation of the sacroiliac joint. It's usually, often it's a diagnosis of exclusion. So again, this causes can be osteoarthritis, inflammatory causes such as ankylosing spondylitis, psoriatic arthritis. Pregnancy can also cause this, and trauma as well. So the SI joint usually is thin, and sometimes what can even happen is the inflammation can basically spread to adjacent structures, and sometimes it can even spread down to L4, L5 dermatome if it's very severe, but generally it's just local type pain. So patients can present with pain in one or both buttocks, hip or thigh region, and pain worse on sitting for long periods, and after obviously like rotation movements when you mobilize that particular joint. So there are different types of provocative tests that we can use to try and help us with this diagnosis. Patrick test being one of them. I've got a video of that a bit later on. So workup for this, so we can check for bloods for inflammatory causes, check for inflammatory factor, ANA, ESR. We can do imaging if we suspect inflammatory cause. But not always helpful. Like X-ray will just show generally sclerosis of the joint or irregular joint ends. CT scan can show sclerosis. MRI can show subchondral edema or marrow edema. Nuclear medicine scans can actually show increased activity of that particular joint. And again, to help with the diagnosis, a local anesthetic test can really help. And again, with treatment for this, physiotherapy is very important, mobilization as tolerated. But if pain reduces the mobility, then we can use intra-articular injections or radiofrequency ablation. Very rarely I saw some cases whereby they can actually do a sacroiliac joint fusion with screws for severe sacroiliitis. So it's basically just an X-ray we can show that shows this massive joint irregularity, subchondral edema, and this is one of those nuclear medicine scans. You can actually see increased uptake in the SI joints. The next one I'm going to talk about is ankylosing spondylitis. This is a chronic autoimmune inflammatory condition, mainly involving the axial spine. It can present with a lot of articular involvement, such as like arthritis of SI joint or lumbar spine, or even tendon involvement, such as enthesitis. Extra-articular features, or extraskeletal features include inflammatory bowel disease, uveitis, or psoriasis. So there is, etiology-wise, there's a genetic component to it. They've established that there's a 67 concordance in monozygotic twins, and there is an association with HLA-B27 as well. Then these patients will present with inflammatory type pain. Basically, it's insidious, it improves with exercise, there's no improvement with rest, and there's pain at night as well. So the workup, again, is generally non-specific. You can do bloods, ESR, CRP, HLA-B27. There is the X-ray grading system for ankylosing spondylitis from 0, which is normal, 1, which is suspicious, 2, which is sclerosis, 3 areas of erosion or sclerosis, 4 is complete ankylosis or fusion. So again, treatment is non-pharmacological, the physiotherapy, rehab, and NSAIDs we can use as well. But if there's no relief, then we can consider intra-articular injections or TNF inhibitors. So this is basically just X-ray showing ankylosing spondylitis. You can see one's grade 3, and you can actually see on the right there's complete ankylosis. The next one we'll talk of is lumbar discitis. So lumbar discitis and osteomyelitis are quite similar in their pathogenesis. So it's an infectious inflammatory process that involves the intervertebral disc. It usually occurs in the setting of either direct inoculation, hematogenous spread, or contiguous spread of an organism. Common organisms include Staph aureus or Mycobacterium tuberculosis. So these patients will present with lower back pain that's insidious, which progresses slowly. It's worse with activity. It's relieved with bed rest. Then on examination, only 42% of these patients will have fever, but there's usually local tenderness and reduced mobility. But of course, if there is sometimes an epidural abscess that forms, then it can compress the spinal cord and you'll have more neurology. But a pure uncomplicated lumbar discitis shouldn't have nerve involvement. Then with regards to bloods, you can do a CRP, ESR, and see if you can grow blood cultures. With regards to imaging for this, MRI is the most sensitive. X-ray really only shows changes when it's advanced. And in some cases, we'll actually need a CT-guided biopsy to help us with the treatment. Or to guide our treatment. Then treatment is usually IV antibiotics based on the culture. If no growth, again, we may need a CT-guided biopsy. So you can see here, this is MRI basically with, we can show this marked signal change at the L2, L3 intervertebral disc. But you can actually see over here, there's actually an epidural abscess that's possibly forming. So this patient, we may even expect neurology. So lumbar spine osteomyelitis, this is it's an infective cause, infection of the bone, of the vertebral column bone itself. So again, it's either due to direct inoculation, hematogenous spread, or contiguous spread. Risk factors include IV drug use, diabetes, the immunocompromised people, infective endocarditis, or prior spinal surgery, even like previous abdominal infections. So it usually affects the metaphysis, which is the most well-vascularized area of the spinal cord. Then these patients will present with back pain, which is exacerbated by physical activity, which is usually localized. They may or may not have fever, and they can have local tenderness, erythema, and swelling. Then again, lab features are basically the same. We'll do FBC, check inflammatory markers, see if we can grow something with blood cultures. Same with regards to imaging, MRI, it's more sensitive. Again, we may need a CT-guided biopsy. And treatment, systemic antibiotics for 6 weeks. So this is just basically a diagram which is just helping, or algorithm helping with management of either discitis or osteomyelitis. So if we have a history and examination which is keeping and the MRI which is in keeping, we have to see if the MRI is not in keeping, then we must find another cause for this back pain. If the MRI is in keeping, we need to ask, is there any neurology, or if there is epidural abscess? If there's epidural abscess or neurology, then we'll have to ask the orthopedic spine or the neurosurgeons to get involved. They can perhaps do a drainage and even try to get a biopsy, and then treatment will be based on what we find. If there's no neurology, or if there's no epidural abscess, then we must ask ourselves, is the patient septic or not? If the patient is septic, then we must start empiric broad-spectrum antibiotics, and then we must check or wait for our blood cultures. If the blood culture is positive, then that's great, we can treat that organism. If the blood culture is negative, then we can ask for a CT-guided biopsy. And then based on those, if we can get the result, then we can treat that particular result. Then if the patient is not septic, we check if the blood cultures are positive. If they're positive, we treat. If they're not positive, then again, we may actually end up needing a CT-guided biopsy again. And based on the CT-guided biopsy, we can treat the particular organism. Then metastasis. So we can get metastatic spread to the back. Like common sources include breast, bronchus, thyroid, kidneys, stomach, uterus. Sometimes in lymphoma or multiple myelomas can actually go to the back. Mets, we can describe them as osteoblastic or osteolytic. So osteoblastic is bone forming, commonly the prostate. Osteolytic is bone resorptive. So these include like the lung, kidneys, thyroid, multiple myeloma. So the osteolytic ones are generally found earlier because they cause pathological fractures. So the hallmark of this is involvement of posterior elements. So the diseases I mentioned earlier on, like the lumbar discitis or the osteomyelitis, usually involves the anterior elements of the vertebra, the intervertebral discs or the vertebral body. So, but the moment we have posterior elements involved, especially like the pedicle, then we must start thinking a metastatic or a non-benign cause of this patient's back pain. So the pain we describe as dull, aching, we can wake the patient up at night. It can be chronic, it's usually chronic. And then if it extends posterolaterally, it can cause neurology as well. Then with regards to imaging, X-ray only detects about once 50% of the bone is eroded. CT is usually helpful. We can actually see bone structures that are well visualized in CT scan, but MRI is of course gold standard. But of course, we'll need to find the primary and treat the primary. So it's basically an MRI, which is showing a patient with chronic back pain. And we can see in both cases, there's posterior element involvement, which is highly suspicious of metastatic disease. Then next, we're going to go to radicular type pain, basically. So this is the next type of pain. Radicular type pain basically is objective loss of motor sensitive function, which is due to a nerve being damaged, either compression, irritation, or stretching. The most common causes we have is herniated lumbar disc, lumbar stenosis, even congenital causes. So with the lumbar discs, so when we've got the intervertebral disc, we've got two parts. We've got the nucleus pulposus central and annulus fibrosus peripheral. The nucleus pulposus is well hydrated, it's got proteoglycans. The annulus fibrosus has got more connective tissue. So with aging, what happens is the water content of the nucleus pulposus reduces and proteoglycans become less. So as a result, the nucleus pulposus can now tear into the annulus fibrosus. And when this occurs, we call it a herniation of lumbar disc. So 95% of all herniated lumbar discs occur in the lumbar spine. Thoracic cord is very rare. Cervical, sometimes it can happen, but most occur in the lumbar spine. So the natural progression is basically from a bulge to a protrusion to an extrusion to a sequestration. I'll put diagrams in the next slide to show that. So the most common age groups are the people aged between 30 to 50. There's a male to female ratio is 2:1. And the most involved discs are the L4, L5, L5S1, or L3, L4. So here's basically the process for lumbar disc or disc herniation. So first process is actually disc bulge. I actually don't have a diagram of that. Disc bulge basically is when the intervertebral disc basically protrudes past the margins of the vertebral body above or below. Then after that, you can get a protrusion or prolapse, basically. So now what's happening, you can see over here, the annulus fibrosus is pushing against the the nucleus pulposus is pushing against the peripheral annulus, but it hasn't yet ruptured it. And then you've got extrusion, which is now it's ruptured past it and into the thecal sac, but it's still attached. Sequestration is ruptured past, and you can actually have free fragments in the thecal sac as well. So with regards to the disc herniation, it can be posterior lateral, or lateral. Most common is posterior lateral. Posterior herniations are very dangerous because you can see over here, if it goes posteriorly, if it's like there's no cord by the lumbar spine, but it can cause even a cord equina type syndrome. But most common is posterior lateral and will involve like the particular nerve that's in that area. So the clinical features will really depend on which nerve is involved. So depending on which is the L4, L5, or S1, S2, that'll determine the clinical presentation. So patients will have pain in the sacroiliac area, which will then radiate down, depending if it's L4 to the medial malleolus, if it's L5 to the lateral malleolus, if it's S1 to the sole of the foot. And they'll usually have some combination of weakness as well, based on which muscles innervated by that particular nerve. And so the neurology would really depend on which nerve or nerves are impinged. So the pain we usually describe as deep, aching, knife or stabbing-like quality. And then there are various maneuvers that can elongate the nerve and cause irritation, such as the straight leg or Lasag's test, the Braggard's, or the Neri sign. I've got videos of that when it comes to the examination part. So weakness and sensory loss will depend on which nerve is involved. EMG will also help corroborate which root is involved. Like we can put the needle into different areas, and if that nerve is if that root innervating that muscles involved, we can have spontaneous activity. And usually these lumbar discs will resolve within a few weeks. So this is basically just a diagram. You can actually see the nucleus pulposus is herniated past the fibrosis now. Then this is going to be an extrusion now. This diagram basically is just to remind us about the anatomy, which nerve root supplies which muscle. And of course, we must also not forget like the reflex level as well. So with regards to management, luckily, most of these will resolve within 6 weeks. So if there's no red flags present, we can use conservative management, which includes analgesia, activity modification. Basically, you must reduce the activities that exacerbate it, and physical therapy. So mobilization as tolerated. Then we only use surgical management if there's progressive neurological impairment, persistent severe symptoms, which is not responding to conservative management, or even if there's a rapid neurological decline. So here's basically a diagram of a patient with a L5S1 disc herniation, and 1 year later, you can see it's gone right back to normal. So this is the natural history of most lumbar disc herniations. Next, I'll talk of lumbar stenosis. So the lumbar canal basically is the area usually between where the spinal cord ends to the terminal part of the spinal cord. So it's usually consisting of the chordae equina, the roots of the chordae equina, and associated structures. So anteriorly, it's bound by the vertebral body. Posteriorly, it's bound by the posterior longitudinal ligament. Laterally, it's bound by the facet joints. So normally, in a normal adult, it's about 12 to 17 centimeters squared diameter of the lumbar canal. So lumbar stenosis is basically when there's pathological narrowing of the spinal canal or the lateral recesses of the neural foramina. So this is usually a disease that occurs to middle-aged and older adults. So this is usually a multifactorial disease. So you usually get degenerative component where there's hypertrophy of the ligaments or facets or disc herniation. Iatrogenic can also contribute post-laminectomy cases. Skeletal disease can cause it or contribute towards it as well. There's also congenital aspect to it as well. So what's going to happen is that because the lumbar canal becomes very stenotic, when you're standing for long periods or walking for extended periods of time, the nerves become compressed, and even the blood supply to the nerves become compressed. So then there'll be like ischemic type pain down that particular nerve root. So patient will present to like pain on ambulation or for prolonged periods of standing. But this is relieved. So this is like called like the neurological claudication. And this is relieved when the patient is sitting down or by forward flexion. And it's usually asymmetrical and can involve the entire leg. And only about 37% of patients usually have some form of weakness. And we need imaging to make the diagnosis to see the tight lumbar canal. And with regards to treatment, if there's no cardiac equina, then we can try a trial of conservative management. So this is basically a diagram I have. You can see a nice, normal, healthy lumbar canal. You can see a nice space there. The intervertebral disc is healthy, facet joint is healthy. Then here is a pathological lumbar canal. So there's lumbar stenosis. You can see this lumbar canal is squeezed on all ends. There's a bit of ligamentum hypertrophy, herniated disc, facet arthropathy. So now this is squeezing the lumbar canal, causing stenosis. And then when you're standing for prolonged periods or moving for prolonged periods, these nerves can become ischemic and hence cause the neurological complication type pain. So I just included the somatic type changes on MRI for degenerative changes. So these are basically MRI changes in the spine due to degenerative disease, which is associated with the lower back pain. So basically, we see a lot of this when we send patients for reports for MRIs. The radiologist does report this, so I thought it's important for us to just go through it. So motor type 1 basically is hypointense in T1 and hyperintense in T2. So this is basically when there's vertebral body edema. If it's type 2, there's hyperintensity in both T1 and T2, so there's patchy replacement. Type 3 basically is hypo in both T1 and T2. So now basically there's sclerosis and destruction of the bone. So here's basically a diagram of type 1, type 2, type 3. You can see type 1, hypo in T1, hyper in T2. So this is just edema. Then fatty change, you can see increased in both signal. And then in type 3, you can actually see hypointense in both T1 and T2. So these usually do accompany chronic back pain as well. So cardiac equina, I thought it's important just to mention this as well. So this is basically a disorder caused by injury to 2 or more of the 18 roots that make the cardiac equina. They present as lower back pain that can relate to one or both limbs. They usually have sensory loss that occurs in that particular dermatome that's involved, but usually perianal is common. And there's usually weakness or loss of bladder, bowel, or sexual dysfunction as well. So you can actually think of it as an evolution. Starts off with pain, then sensory involvement, and then loss of bladder and bowel. So common causes include trauma, degenerative changes, disc prolapse, spinal stenosis. Could even be a non-benign, like a primary non-benign or metastasis, or even infectious. So this is a surgical emergency. We need to image these people urgently and then treat based on what the cause is. So just to mention also there could be congenital causes as well. Congenital lumbar stenosis. Basically, this is when the pedicles are just abnormally short. Congenital scoliosis or disraphism, all those spinal type disorders can also cause lower back pain. Then referred pain. This is when there's pain from other structures that are referred now to the back, usually from the pelvis or abdominal viscera. So, but usually these pain does not actually have any relationship with the movement to the back. These include things such as peptic ulcer disease, constipation, abdominal aortic aneurysm, pancreatitis, pyelonephritis, different types of cancers, retroperitoneal mass, ovarian cyst, cancer, pregnancy. So it's very important that you do a proper examination when you see a patient with back pain so that we can exclude other causes or referred pain. So these are basically just diagrams which showing different patients who will also have back pain. You can see severe constipation, with a severe mass, most likely ovarian. You can see a AAA, you can see pancreatitis. So these can also cause back pain. Then funicular type pain, I thought of just mentioning a few words about this as well. This is usually tract pain. Usually occurs in the setting of intramedullary tumors, syrinx, or cord. We did say this pain they describe as continuous, poorly localized, deep, hot or cold. So we did say earlier on that the spinal cord doesn't have any nociceptors. But what happens in these cases, usually when there's irritation of those tracts, the spinal thalamic tract mainly, there can be mechanical deformation. And sometimes they say it's enhanced sensitivity of the damaged axons or it's interruption of the pain modulation pathway. So you get this non-specific type of pain as well. So when patients present to us with back pain, it's important that we examine them and take a good history so we can try and narrow the cause. So when you take history, you must ask about onset. Is it acute? Is it chronic? This can help us with the causes. If it's acute, it could be a sudden strain or a sprain or a herniated disc, or a spinal stenosis or a fracture. If it's chronic, it would be arthritis, previous injuries, malignancies, or like fracture. The location also helps us as the midline or paracentral. If the pain radiates down, then I'm thinking radicular type pain. Check for aggravating factors, check for the characteristic type of factors. So those all help us to try and differentiate what type of pain we're dealing with. Then we need to ask for family history of cancer, check for family history of back pain. So there is actually a marked genetic component for back pain as well. See what on social history, see what work they're doing. Do they smoke? Do they use IV drugs? Past medical history, see if they've got previous cancers, psychiatric illnesses, or even previous arthritis. So whenever we take a history, we must always go through red flags as well. So there's neurological red flags for cardiac quinine. We must always ask for bladder and bowel dysfunction, sexual dysfunction, saddle anesthesia, or if there's bilateral weakness. Check for severe neurological involvement, such as rapidly progressive deficit, prominent motor weakness. The red flags for cancer include previous cancer, unexplained weight loss, pain worsens supine position, people that are of elderly age, fractures also red flag for cancers, chronic steroid use. So red flags for infection include fever, recent IV drug use, recent infection, immunosuppression. Then we must also go through yellow flags. So this basically is an indicator that patients that you have might actually end up having chronic back pain. So these are usually point towards psychosocial factors that can contribute towards pain. So you must ask about depressive mood or negative mood, if they've got any social issues, if they believe that a particular activity is harmful, or if they've got unhealthy behavior, like they insist on staying home for prolonged periods, if they've got previous treatments that they don't obey basically what the advice we give them, if they exaggerate in their hope, if they use excessively medical certificates, if they've got problems at work, problems at family. So these basically lean towards the fact that these patients might develop chronic back pain, and we must identify them quickly so that we can start acting on them and referring them appropriately so that we can deal with them more holistically. So when we examine these patients, we must go to general examination first, to check temperature, check lymph nodes, check wasting. Then we inspect, we start to inspect the patient, check the curvature of the spine, check for any edema, scars, or swelling. We must palpate basically each spinal process, see if there's any step deformity, see if there's local pain or muscle spasm. We can actually palpate the sacroiliac joints. Then we must do a motor exam. So this could depend on which myotome is involved, basically. But unconfirmed, usually sometimes patients may have giveaway weakness, so we must be on the lookout for that as well. It's the best attempt a patient can give. Then reflex is important to see if there's a reflex level, is it L2, is it S1, that can also help localization. Then of course, don't forget, we must also examine the cardiovascular system, abdominal system, to see if there could be a cause of other referred back pain. So this again is just another diagram with the root level, the pain distribution, and dermatomal level, because if it's radical type pain, we can work our way back to see which level is involved. And there are special tests that we can do for back pain. So here's a video of basically the straight leg Braggards and Neris. So basically, in these patients, patient must be lying supine, then their knee must be extended. They're going to flex the knee, flex at the hip joint basically. And then where the pain develops is very important. Between 0 to 30 degrees, it's not supposed to be from nerve involvement. From 35 to 70 degrees, it's usually due to stretching of the nerve. More than 70 degrees is usually joint pain. That's a straight leg test. Then there are two variants basically of the straight leg test, the Braggards and their Neris. They're going to show it just now. So the Braggards, what we do is we find the area where there was pain, like let's say it's between 30 to 75, then we go a bit below it, out of the pain area, as he's doing now, and then you're going to dorsiflex the ankle, and that should elicit pain if it is from nerve or from root. That's a Braggards. Alternatively, you can ask the patient to flex the neck, and that's the Neri sign. So this is basically testing for nerve root irritation. Then femoral stretch test. This basically asks the patient to, this is when there's pain on the anterior thigh during this procedure. So you ask the patient to lie prone, then you're going to flex the knee joint, and then you're going to just literally pull it up and see if there's pain at the hip, at the anterior thigh. If there is pain during this procedure, you can, this usually indicates the L2 to L4 root compression. Then this is the Patrick test. This is to test for like sacrally actuated involvement. So basically, in this patient, you're going to cross the infected involved leg. Then you're going to stabilize the opposite pelvis, and then you're going to lower down that leg at least up to the level of the opposite leg. And if they can do that, then usually it means that that joint is not involved. Then with regards to investigations, the American College of Physicians and College of Family Physicians have advised that if there's no red flags and the pain is less than 6 weeks of duration, no imaging is needed. For these patients, conservative management is very important. It's actually been shown early imaging has not affected decision outcome or has not improved outcomes either. So it has not affected decision making or has not improved outcomes. And some studies have actually even shown that there's better outcomes with conservative management. But of course, if we have to do imaging, then we can start with the lumbar X-ray. The issue with lumbar X-ray is that we can just see bone alignment, you can see the joint, and the level of radiation we have here is actually markedly high. It's almost 100 times more than the normal chest X-ray. So females of childbearing age, this is a particular concern. Then with regards to MRI, of course, it is especially for neurological conditions, it's the investigation of choice. We can see the cord, we can see the roots, and we can see the discs very well with this MRI. CT scan is superior to MRI in visualization of bony structures, but not the soft tissues. That's fine. So EMG can also be helpful. Basically, it can help us tell if a particular root is involved, because then we can know if we know that if which muscle is involved by which root. We put the needle in the muscle, if there's spontaneous activity, we know that particular root is involved. But we have to do different routes to see different muscles which innervate with the same root. We expect those to be involved. Then treatment of lower back pain will depend on the time frame and whether or not there's red flags. If there's red flags, this patient needs urgent imaging and treatment based on the cause. So if it's an acute back pain, if it's radicular or not radicular type pain, if we've excluded red flags, management is basically pain control, preservation of function, which is just conservative management. So this includes pharmacological things such as NSAIDs, muscle relaxants, anti-epileptics, if it's a radicular type pain. And non-pharmacological, which is very important, is exercise as tolerated, core strengthening, heat therapy. You can even go for acupuncture. Cognitive behavioral therapy is very important as well, especially if we've got yellow flags in these patients. Then we can counsel these patients that if it's musculoskeletal, up to 90% just improve by spontaneously with conservative management. If it's radicular type pain, up to 88% improve with conservative management. Steroids and radicular type pain has shown that there's like 50 days of steroids have shown improvement at 52-week function, but does not change the long-term outcome. Then we have to reassess these patients every 4 to 6 weeks, looking for red flags. If there's red flags present, we have to consider imaging. Or if patients don't respond to conservative management, we can consider imaging them as well. So this is basically just different types of medications and the level of evidence for the different types of medications. So this diagram basically is just a summary of what I said, if it's musculoskeletal or radicular type pain. With either of those, if there's red flags, you image directly and your treatment is based on what you find. If there's no red flags, conservative management, reassess. If they've improved, well and good, we can stop. If they have not improved, again, check for red flags. If there's no red flags, you can try another conservative therapy, or we can actually consider imaging as well. Same thing with radicular type pain. The only thing is that we can add anti-epileptic drugs in this case as well. And also there's also a role for EMG in radicular type pain. So chronic back pain, this is pain that persists for greater than 12 weeks. We have to tailor the treatment to the patient. So we have to look for risk factors that are associated with the transformation from acute to chronic, basically. So we must look at psychosocial factors, patients with anxiety, depression, job dissatisfaction, if there's pending litigation at work, workers' compensation, smoking, previous history of back pain. So we must treat based on the previous modalities used, and we must tailor it based for this patient. Evaluate all psychosocial factors. Again, evaluate for red flags. We should also consider imaging for these patients. The other thing is, so the other reason why cognitive behavioral therapy is very important is you get this negative feedback loop. Well, if a patient had a pain generator in the back and a particular movement is associated with pain, then they get trained to believe that that movement will always be associated with pain, even if the pain generator has resolved. So this is also like there's a marked cognitive aspect to back pain as well. So we need to get these people to have CBT to help, and it does help with chronic back pain. And the pharmacological treatment, NSAIDs, if they become contraindicated, then you can use Panado, then you can use SNRIs like duloxetine or tricyclics like trepoline. Muscle relaxants like baclofen does help. Botox and spinal muscles can also help. But non-pharmacological is very important for these patients. You need an MDT, you need a physios or a psychologist as well. Then surgery, it's indicated generally if we get cauda equina syndrome or if there's radicular type pain with a progressive neurological deficit or if there's spinal stenosis. So it's usually if there's marked neurology, then we can, and we've diagnosed it, we can then ask our orthopod spine, so neurosurgeon spine or orthopedics to get involved. So we have to look after our spine. We can't transplant as just as we like what they advise basically is just to do the simple things correctly. Exercise as tolerated. Core strengthening is very important. Avoid smoking. Avoid smoking basically. Try to keep your spine healthy. Then hopefully we don't end up with chronic back pain. Thank you.